First, we will discuss what are the topics very important for our interviews. Okay. So, if you want to go for interviews, first modifiers are very important. So, where do you get the modifier information? So, you will get this modifier information on my YouTube channel also. So, go to CPT playlist. Okay. And next one is any three chapters. Like we are having 1, 2, 3, 4, 5, 6 series, correct? Any three series chapters. Like most of the time they will ask Q&A from integumentary, musculoskeletal and digestive. So these are the most important topics from the system wise they will ask in the interviews. Okay. And also you need to understand updates 2025 ICD as well as 2025 CPT. Okay. As in surgery also we will use ICD-10 CM, correct? So they will ask updates related to ICD-10 CM as well as CPT. So these both are available on my YouTube channel. Okay. Next to other than this they will not ask anything. So we will check during our session now. So basically now I am not going to share anything to you. Just I will ask the question. You need to tell the answer. Okay. So what is a modifier, guys? What is a modifier?
It's a two-digit code appended to CPT
Yes.
so that it will increase the accuracy of, not accuracy, it'll give a more detailed information about the CPT.
Yeah. So basically modifier is a two character or modifier consists of two
Numerical code.
characters like alpha character and numeric character, which will provide additional information about the CPT code. So which will not change the CPT code description, but it will provide more information related to that CPT. Then you need to tell few examples related to those modifiers. Okay. For example, you need to tell 22 modifier. So what is a 22 modifier?
Increased procedural service.
Yeah, increased procedural service. So here you are not changing the CPT code description, correct? But it is changing or like informing that there is a separate situation along with this code. So here we are telling the insurance payer that so we have performed this procedure, but it took more time due to patient's complexity or patient's obesity. Okay. So then what is the difference between 22 and 52?
52 is a reduced service.
Okay. So in colonoscopy, when do you use 52 modifier?
For therapeutic colonoscopy.
Yeah, perfect. If the physician is unable to cross or reach cecum, we will use 52 modifier, correct?
Hmm.
Yeah, no problem. So what is the difference between 24 and 25 modifier?
24 is significant and separately identifiable ENM service by the same physician during post-operative period.
Okay.
That 25 is significant and significant evaluation and service by same physician during same day of the procedure.
Yeah, perfect. So
Period is
basically,
major.
yeah, correct. So basically 25 is significant separately identifiable E&M by the same physician or other QHP on the same day of the procedure or other service. Okay. So 24 is related to global like post-operative period of initial surgery. So for example, patient is having the surgery on June 1st. So physician has performed 90-day global period procedure. Okay. June 8th, patient again came into the hospital, but not related to this initial surgery. So which is not related to this initial surgery, and patient came in for separate condition on June 8th. Okay. So that time physician has performed the E&M to the patient. So that time we can append 24 modifiers. So basically 24 means unrelated E&M service by the same physician or other QHP during the post-operative period of a initial surgery. Okay. Okay, fine. So what is the difference between 26 and like TC modifier?
26 is professional component and TC is technical component.
Okay. So for example, a physician interpreted the report and the equipment is owned by the like hospital. For physician, which modifier you will use?
26.
Yeah,
26
26. Perfect. For facility?
TC.
Yeah,
TC.
perfect. Yeah, correct. So then what is the difference between PT and 33 modifier?
PT modifier used for Medicare payers.
Okay.
For non-commercial, we will use 33. PT for when we will use means if there diagnostic colonoscopy converted to therapeutic, in that case we will use PT
Yeah, perfect.
based on payer.
Yeah. So little bit correct. So that is correct. So basically, if the patient came in for screening colonoscopy, okay. So during the screening colonoscopy, if the patient performs any type of therapeutic procedure, we need to use two modifiers, 33 and PT. Okay. So we will use 33 modifier for other than Medicare or commercial payers. Okay. We will use PT modifier for Medicare payer. So what is important? Whenever you want to code screening colonoscopy, what do you need to check, guys?
It's a Medicare or
Yeah,
Medicaid.
perfect. So only for mostly for screening. So you need to check whether it is Medicare or non-Medicare. Okay. So what is the difference between 51 and 59?
51 is a multiple procedure is doing in the same anatomical area.
Perfect.
That 59 is a distinct procedure service in a different site or a different physician or
Different incision also.
yeah.
Okay. So basically 51 is for multiple procedures. So same location or same anatomical location, same physician will perform multiple procedures. Okay. 59 criteria is physician needs to perform multiple procedures on different anatomical location. Physician needs to perform multiple procedure using the multiple incisions. Okay, so that one you will call it as 59 modifiers. So what are the variants of 59 modifier?
XU, XU, XE, XP, XS.
Yeah. So what is the difference between XS and XU?
XS is separate.
XS is a separate procedure. Structure.
Yeah.
XU is not separate structure, but different anatomical site and the same structure.
So non-overlapping service.
Yeah.
Okay. So fine. So what is the difference between 52 and 53?
52 is reduced services. 53 discontinued services
Okay.
due to patient's well-being.
Yeah. Okay, fine. So what is the difference between 54 and 55? So use your CPT book. So if you read it now, you can remember. Not a problem.
54 is the surgical care only.
Yeah, perfect.
55 is a post-operative.
Yeah,
Management only.
yeah, correct. Okay. So next, 54 surgical care, 55 post-operative management, 56 pre-operative management only. Okay. So what is the difference between 25 and 57?
25 is for minor surgeries of global period of 0 and 10. 57 is for 90-day global period.
Yeah, perfect. So basically, so where do you append these E&M modifiers? CPT code or E&M code?
ENM code.
Yeah,
ENM
perfect.
codes.
Yeah, you need to append it to E&M code. Okay, fine. So so physician has performed June 1st breast biopsy and June 8th mastectomy. Which modifier you will use?
58.
Why 58?
It's the same. It's a plan. Related services in a global period. Stage related services.
Yeah. So basically here physician has performed the initial biopsy on June 1st and then he performed major surgery or mastectomy on June 8th based on the previous results. June 1st result. So this is a planned procedure. Okay, so that is fine. So next, what is 62 modifiers?
Multiple surgeons.
Yeah, two surgeons. Mostly he will use,
Surgeons as primer.
yeah, yeah, perfect. So two surgeon needs to act as primary surgeons. So where do you find in the CPT? Which section of CPT you will find this code mostly? Spine procedures. A spine procedure is a complicated procedure. Most of the time, physician will use or both physician will work. Okay. So what is the difference between 77 and 78? Sorry, 76 and 77. 76 and 77.
76 for repeated procedure by same physician.
Okay.
77 is repeated procedure by different physician.
Yeah, perfect. Okay. So what is the difference between 78 and 79?
Unplanned and unrelated
Yeah. So basically
procedure.
78 is unplanned return to the OR during the post-operative period. 79 related procedure are serviced by the same physician. Okay. This is also during the post-operative period. Okay, fine. After this, they will not ask anything mostly. So next, how many types of modifiers we have?
3 types.
2
What?
levels.
Overall, two types.
Two
CPT
types.
level 1
Alphanumeric and
modifier.
number.
Oh, okay.
Yeah. HICPICS level 2 modifiers. Okay. So it's fine, guys. So we have learned all these things. So physician has performed procedure on the right hand middle finger. So which modifier you will use?
RT modifier.
F7.
Yeah,
No,
perfect.
no, F7. Yeah.
So you need to append F7. Okay. So when do you use finger like toe modifier and when do you use foot modifier?
Footer, if the physician is doing procedure on the right or left foot means we can give RT or LT.
Okay.
The toe modifiers, if the procedure is
The
doing
musculoskeletal 2 series procedures.
Yeah. So basically most of the time if the patient performs procedure on the or procedure up to metatarsal or metacarpal. So metatarsal and metacarpal comes under foot. Okay. Phalanges comes under toes and fingers. Okay. If the patient performs procedure on the up to metatarsal, we need to give right and left. If the patient perform procedure on tarsals or metatarsal, we need to give toe or finger modifiers. You no need to worry, your encoder will guide you. which modifier you need to use. Okay. So next, what is the place of service code for ambulatory surgery center?
23.
24. Check once.
Yes, 24.
Yeah, no worries. Just try to remember.
24.
So sometimes they may ask you 24.
24
ER
for
is,
emergency room.
yeah, perfect. So just as we are concerned about, just you need to remember three settings: 21, 23, 24. 21 is for inpatient hospital, 23 emergency room, 24 ambulatory surgery center. Okay. So next, what is a global period?
Post-operative period or
10 days
recovery.
is minor and 90 days is major.
Yeah. So basically, you need to tell the definition here. Okay. So basically, these global periods are divided based on the recovery after the surgery. Okay. For minor procedures, we are having 0 day and 10-day global period. Okay. For major procedures, we are having 90-day global period. Okay. So as a definition, you need to tell. So global period is the period where few component procedures are included in the performed procedure or major procedure. Okay. For example, if you take one major procedure, so which includes evaluation management on the day before and day of surgery, local infiltration, immediate post-operative care, okay, writing orders, evaluating the patient in the post-anesthesia recovery area, typical post-operative follow-up care. So these all are included in 90-day global period. Okay. So how many types of global period we have?
3 types.
Yeah,
Three.
three types.
0,
Okay.
10, and 90.
So for example, patient had like lesion removal on June 7th. Okay, it is having 0 day global period. And June 8th again patient came into the hospital for complication related to that procedure or initial procedure. How do you code? How do you code,
We
guys?
have to do separately.
Yeah, for
Only
example,
post-operative room.
Simply we can code.
yeah. So basically here 0 day does not have any post-operative or pre-operative component. So you need to code separately again. For example, June 7th patient had the benign lesion excision or endoscopy, for example, like colonoscopy. So colonoscopy is having the 0 day global period. So June 8th patient is having bleeding due to colonoscopy. So again you need to code bleeding as a
Separately.
separate procedure. So you can't code it as complication of colonoscopy. Why, guys?
0 day global.
0.
Yeah, perfect. 0 day global period. So in that way you need to think. Okay. Next. So any doubt in modifiers? So those are very, very, very important.
Could you please explain 57?
57
Because
is for
I'm
57 is for major procedure. Along with the indem, if the physician decides to
when we can
perform
apply.
major procedure, we need to append 57. Okay.
Decision for surgery. Yeah,
Yeah.
I know. But my question is when the doctor is performed first surgery, uh, after that patient has come for next 3 4 days. Again, she decided to surgery. That's time we can append
57 only.
57 only.
Yeah. So not 57. So if you see the definition, See here, what is included in global period? E&M subsequent to the decision of the surgery on the day before and day of surgery. Means only one day. For example, June 1st, patient came in for evaluation management and physician decides to perform major surgery. But he will not perform surgery on June 1st. June 8th, physician will perform the surgery. June 1st, you will give 99202 99214 series codes. Only evaluation management. Okay. June 8th, you will append the CPT code. Here you will not append 57 modifier. So what is the reason?
So that they not perform surgery.
Yeah. So basically,
Decision for surgery.
yeah, decision for surgery is needs to perform before the day of the surgery. Got it?
Then that first time we have to give that ENM and that 57
No,
modifier
no, no.
only. No.
No, we will not give 57 modifiers. We will not use. There is a gap between E&M and surgery. If it is only one day only, we will give 57. See the definition in the book. What are included in global period? E&M subsequent to the decision of surgery on the day before and or day of surgery. Day before. So for example, today is June 8th. So patient came into hospital on June 7th. So June 7th, patient has decided to perform major surgery. So that time you can give 57 modifier. So the gap must be only one day between original surgery and evaluation management. Got it?
Okay, sir.
Clear na? So if you see your CPT book, they have clearly mentioned decision of surgery on the day before and day of surgery. So that is
Okay, then my
That,
question
yeah,
is if
that gap is long. So that time
sorry.
that gap is more than 5 days, six
Yeah, you
days.
need to code
Then
separately. So for first initial visit, you will code E&M code. For second visit, you will code normal CPT code. You will not append any modifier. If the gap is more than one day. Okay.
So after 2-3 days, we should not open 54 modified to procedure board also.
No, no. 54, 55,
We
56
can open.
mostly we will use for like OBGYN procedures.
Okay.
In facility coding, na, we
OB
will not.
gynec procedure.
Huh?
OB gynec.
Yeah, yeah. So mostly we will not use those codes in the facility setting. Okay. So just if the gap is just remember like that. If the gap is only one day between E&M and major surgery, we can append 57 modifier. If the gap is more than one day, we will not use CPT like 57 modifiers. We will code separately. Okay.
Okay, sir.
So
Okay.
yeah. Anyway, good question. Thanks for asking.
Mhm.
So just if we see that one, so what are the components in the major procedure, you can understand that. They have clearly mentioned surgery on the day before and day of surgery. Then only you can append 57. Okay, next. What is the separate procedure?
Two different procedures.
So basically, separate procedure is a procedure which is a component of major procedure. Okay. If the patient performs major procedure and separate procedure on the same anatomical area, which one you will code, guys? Will you code one codes, two codes?
one code.
Yeah.
One code.
So why means separate anatomical structure, you can't code separate procedure. Sorry, same anatomical structure. So for example, physician has performed one major procedure on the arm and one separate procedure on the knee. How do you code this procedure? Will you code
This
one code, two
procedure.
codes?
Two codes.
Yeah,
Yes.
perfect.
2 codes.
Why means there are two different anatomical structures, correct? So you need
Yes.
to
Yes,
code
sir.
two codes. Okay, and which modifier you will append?
59.
Yeah.
25 and 59. ENM for 25.
Yes.
No, no, only 59. So just we are
Okay.
telling that Fishni has performed one major surgery and minor like separate procedure on different structures. Okay, 1 second. So separate structures. Okay, fine then. So next. So when do you use unlisted code?
If there is no related course, we couldn't find out to related course of that system, then we can append that
Yeah, yeah.
unlisted.
So basically, unlisted code is the code. If you are unable to find any CPT code related to uh, exact procedure based on the operative report, we will append this unlisted code. So will you append modifier to unlisted code?
No.
Yes, we
No.
can
Yes.
append. So this is the latest guideline. So we can append modifier to unlisted code. Okay. So what is the difference between destruction and excision?
Destruction is destroying the tissue and will not have any sample for a path.
Yeah,
But
perfect.
excision is we'll get a tissue and we'll send it for pathology.
Okay, good. So in the
That
operative, yeah, go
I
ahead.
have one doubt. Which are the modifiers we can append to that unlisted codes like RTLT
Yeah,
59?
informational modifiers.
Oh,
Okay,
okay.
so basically we are having three types of modifiers.
Mm.
Payment modifiers, next to informational
Pricing.
modifiers and pricing modifiers. Okay,
Yeah. Mm.
so what is a foreign body?
Any external object enter in the our body.
Yeah, so basically based on CPT, so that is one option. So when external object came into the body, we will call it as foreign body. And one more definition is, for example, patient has inserted the stent in the ureter. Okay, but that stent become clogged and it is not working properly. So that time that stent will become foreign body. So basically, if the implanted device will act its intended purpose, we need to consider it as foreign body. Okay, so that is the CPT guideline. Okay, fine. So what are the layers of skin?
Epidermis, dermis,
The
and subcutaneous.
Dermis, subcutaneous.
Yeah, perfect. Epidermis, dermis, and subcutaneous tissue. Okay, fine. So what is the difference between FNA and biopsy? Core needle biopsy?
biopsy means sample.
Okay,
In FNA, we get fluid as sample. We'll aspirate fluid.
okay.
In biopsy, we do incision and get tissue. And FNA, we send it to cytopathology
Cytology.
and
Yeah.
sorry, cytology. And in biopsy, we send it to histology.
So for example, we are having the operative report. So Fishni has mentioned I have used the needle and I have removed the sample. Which one you will use? FNA or biopsy?
FNA,
Yeah, yeah,
FNA,
perfect. So most of the time for FNA, Fishni will use the needle. Okay, for biopsy,
incision.
yeah, perfect. So Fishni will create an incision and he will perform the harvesting of the biopsy sample. Okay, next. So incision. So what is incision drainage?
Any type of pus and bumps created on the body. That times doctor get incision
Yeah.
and remove that total abscess. and drainage. That was
Yeah, correct. So basically, in order to code incision and drainage code, in the operative report, must and should you need to check whether patient has performed any incision or not. Without incision, you can't code incision and drainage code. Okay. So what is the difference between simple and complicated IND?
Simple, they won't do packing and locations and all, but in complex, you will do multiple locations
Yeah.
and will get
internal
packing.
fixation.
No, no, no.
It's complicated.
No, not fixation comes under musculoskeletal. Yeah. Simple is single incision or if the incision drain is performed on the like superficial layers. So complicated means if the patient uses multiple incision as well as if the patient uses the packing in order to close or stop the drainage. So that time we will use complicated. One more definition is if the patient performed IND of only one abscess, we will code it as simple. If the patient performs IND of more than one abscess, we will code it as complicated. Okay. So same definition you can use for pilonidal cyst also. Simple and complicated. Okay. So what are the debridement guidelines?
It's based on depth.
Yeah. Otherwise they may ask you how do you code debridement? So whenever you want to code debridement, few criteria you need to follow. First one is depth of the tissue patient performed the debridement, and you need to check square centimeter or surface area how much patient has performed the debridement. So debridement divided based on subcutaneous tissue, medullary fascia and bone level. Okay, and you need to check square centimeter. So if the patient performs like documentation contains, so I have performed debridement of the muscle 5 into 5 centimeters on the yeah. How do you code that one? Debridement of muscle 5 into 5 centimeters. Which code you will use?
25 square centimeter.
Yeah, which code you will use? Muscle level. Anyone? You will use 11043 and 11046. Okay. 5 into 5, 25. Or muscle level. I told muscle level. So you need to code this one. 11043 and 11046. Okay. So here the guideline is that if the patient performs same location, different depths, we need to code deepest level. For example, patient has performed debridement of bone level. You need to code bone level code in different location. For example, in the arm and in the leg. Patient has performed the bone level debridement. Will you code single code or multiple codes? So single code we need to use. Same
Same
level,
depth we could want.
yeah, same depth you
Single
need to
code.
combine. Different depth you need to code separately. It's simple. Then you need to append 59 modifier or excess modifier to lesser value code. Okay, so that is the guideline basically. So just remember same depth on the multiple locations combine. Okay, different depths on multiple location code separately. That's all. Okay. Next, so what is the difference between biopsy and excision? So basically biopsy is a
Biopsy is
diagnostic.
diagnostic.
Yeah, yeah. Go ahead.
Biopsy is diagnostic and excision is therapeutic.
Yeah, perfect. So during the using by diagnostic, patient will perform examination of the tissue removed. Okay. So in the like excision, patient will perform definitive procedure. So that is the difference. Okay. What are the types of biopsy?
Three types:
Yeah. What are those?
incisional, incisional, punch, and tangential.
Yeah. Perfect. What is the hierarchy of biopsy?
Incisional, punch, and tangential.
Yeah. Perfect. Incisional, punch, and tangential. So here they will not ask anything. Removal of skin tags not necessary. So tell me few examples for benign lesion.
Asking the conditions, right?
Yeah, most of the time benign neoplasm, cicatrix. So cicatrical means,
Like
so basically cicatrical means scar. If the patient is having previous surgery and now patient came in for excision of the scar, we will use benign lesion excisions. Okay. So what is excision? So excision
ex-
is defined as a full thickness removal of skin including margins and includes simple closure when performed. Okay, so just try to remember excisions include simple closure. You don't need to code separately. Okay, so how do you code if the patient performs excision of three benign lesions? Will you
Three
code?
coats.
Yeah, perfect. Three codes. You need to use three codes separately. Okay, so when does the patient takes need to take the diameter of the lesion before surgery or after surgery, which is appropriate?
Before surgery.
Yeah, perfect.
Before surgery.
Yeah, before surgery. So what is a margin?
Surrounding area of the lesion
Yeah,
that
yeah,
physician removes.
yeah, which is the most narrow margin required to adequately excise the lesion. Okay, so next, so physician has performed benign lesion along with adjacent tissue transfer code. How do you code? Will you code single code or multiple codes?
Single cord.
Yeah,
Only ATT.
yeah, only ATT. Okay, so same guidelines you will use for malignant lesions also. Okay, so for example, sorry, so physician has performed one lesion excision on the scalp, one on the trunk. How many codes you will code?
2 cords.
Yeah, two codes. Perfect. So based on CPT guidelines, we need to code each benign lesion excision code separately. Okay. Yeah, that's simple. So now they will not ask anything here. So same guideline you need to use for malignant lesion also. Okay. So physician has performed malignant lesion excision, but during the excision, so pathologist told like margins are not sufficient for examination. Okay. Which modifier you will use?
22.
58 modifier.
Okay.
So append modifier 58 if the re-excision procedure is performed during the post-operative period of the primary excision procedure. Okay. So here they will not ask anything. So what is a pilonidal cyst? So spinal nodal cyst is the cyst on the back side or coccyx area most of the time. Okay. So what are the repair guidelines?
The three types of repair: simple, intermediate, and complex
Based on the layers and
layer.
materials, we will decide the type of repair.
Yeah. So basically we are having three types of repair. Simple repair means single layer of suturing. Okay. And intermediate repair means patient needs to perform multiple layers of repair, and along with, if the patient performs single layer suture along with heavily contaminated wound cleaning, you will consider it as intermediate repair. Okay. And also if the patient performs limited undermining, you need to consider it as intermediate. Okay. So what is complex? Here also same, including repair, what do you call this one, intermediate. Here also repair includes multiple layers. Okay. And also
So
patient needs to perform repair on bone, cartilage or tendon. Okay. And complex repair includes extensive undermining. So in the operative report, for example, if you see, I have performed extensive undermining in order to code, in order to perform the this repair, you need to code it as complex repair. Okay. So physician has performed like malignant lesion excision along with simple repair. How many codes you will code?
One.
Yeah, one. So physician has
Simple repair
performed.
already included.
Yeah, perfect. So physician has performed malignant lesion excision along with intermediate repair. How do you code?
Two.
Yeah,
two
two
codes.
codes. Yeah, you need to code excision as well as
Intermediate repair.
Intermediate.
intermediate repair. So physician has performed benign lesion excision with complex repair. How do you code?
Two codes.
Yeah, here
Two
also two
codes.
code. Just the guideline here is that simple repair is included in all excision procedures. In the integumentary section, if the patient performs excision and intermediate or complex repair, we need to code it separately. It's simple. Okay. So what is ATT?
Adjacent tissue transfer.
Tissue transfer.
Yeah, perfect. Adjacent tissue transfer. So what is adjacent tissue transfer? So just simple now, adjacent, nearby tissue. If the patient is having the defect, patient will perform the incision and he will transfer adjacent nearby tissue to the diseased area into the diseased area. Simple, adjacent tissue transfer. Okay. So how do you find adjacent ATT in the operative reports? Just here you need to remember keywords. For example, if the
Flaps.
documentation contains G plasty, V plasty,
Plastic.
VY plasty, rotational
Plastic.
flap, or advancement flap, or transfer of the tissue. So then you will use adjacent tissue transfer codes. Okay. So how do you code adjacent tissue transfers? So whenever you want to code ATTs, you need to combine primary defect as well as secondary defect. Okay. So for example, patient is having the defect on the arm area. Okay. So that is primary defect, like 3 centimeters. Okay. And in order to close that defect, physician has performed the secondary defect for flap design. So that is 7 centimeters. So how much it is total on the trunk area? How do you code this scenario? So primary defect is
10.
3 centimeter. Secondary defect, which is used for flap construction, is 7 centimeters. How do you code on the trunk area? Which one you will use?
14000.
Yeah, perfect. 14000. Here you will not multiply per square centimeter. So based on CPT guideline, we need to combine primary defect size and secondary defect size. Okay, so that is the guideline. So what is skin replacement surgery?
Basically, they will,
Tomography and
yeah, by grafting, they will insert the skin from the other area
andrograft
other
and
than.
Yeah, simple basically. Skin replacement surgery means physician will replace the skin. That's all. So guys, if it disconnects, you can join again. Okay,
Okay.
and it's simple basically. So what is autograft?
Say
Graft
from
taken from
the
the same person.
Yeah, if the patient takes graft from the patient's own body, we will call it as autograft. What is allograft?
other.
Yeah, other. Okay, so what is the difference between skin replacement surgery and skin substitute graft? So most of the time for skin replacement surgery, we are having two types of scenarios. So skin replacement is here physician will replace the skin or damaged skin. In skin substitute, physician will use other than autograft. Okay, so that is the difference between the skin replacement and skin substitute grafts. Okay, so these skin replacement surgeries based on the recipient area, not the donor area. Most of the time, in the operative report, you will see donor and recipient. So recipient means what is the recipient area, guys?
who is accepting that
Yeah, perfect. Okay, donor means
who is donating.
yeah, perfect. Yeah, it's simple. So here they will not ask anything. So what is the difference between split thickness and full thickness graft?
Split thickness is only dermis and epidermis. Full thickness is dermis, epidermis, and subcutaneous.
So basically we are having multiple definitions. So split thickness means dermis, epidermis plus part of the dermis. Okay. Full thickness means complete epidermis and dermis. So you can tell either way. Okay. So what is the difference between flap and graft? So basically flap means if the physician performs grafting. So if there is a connection between recipient area and donor area, we will call it as flap. Okay. If the physician performs a procedure where there is no connection between recipient area and donor area, we will call it as graft. Got it, guys?
Yes.
Okay, fine. So next, here they will not ask anything. So what is the difference between liposuction and lipectomy? First tell me what is liposuction. Tell me the difference, lipectomy and liposuction.
Liposuction is the removal of excess fat from specific body area.
Okay. What is next one?
Lipectomy is the surgical removal of
Yeah,
fat tissue from
yeah,
the abdomen.
yeah. So basically here, based on the technique, we need to choose the code. Okay. So lipectomy means physician will perform the incision and he will dissect the tissue and he will remove the uh,
Fat tissue.
fat tissue. Okay, in liposuction, instead of incision or dissecting the tissue, physician will use the needles and trocars in order to remove the fatty layers. Okay, based on approach. In the operative report, if you see I have used the suction techniques and I have used the needles or trocar, you will use liposuction. But instead of that, if the physician mentions, so I have performed the incision and I have dissected the tissue and I have removed the fatty tissue. What do you use, guys? Ectomy or a suction? Yeah,
Lipectomy.
yeah, perfect. Lipectomy. Okay, so that is the difference. What is abdominoplasty?
Surgical repair of abdomen.
Experience abdomen.
Yeah,
Surgical repair
yeah,
of abdomen.
yeah, perfect. Uh, okay. So how do you code if the patient removes sutures not using anesthesia?
We will code E&M.
Yeah, perfect. So if the patient does not use anesthesia, we will use E&M code. If patient uses the anesthesia,
Separately coded.
yeah, perfect. We will use surgery code.
Yes.
So what is a pressure ulcer?
Bed sore.
That
It's a
is
decubitus like.
the spine.
Yeah, so yeah, other name for pressure ulcer is bed sores. Most of the time, like these pressure ulcer occurs due to continuous pressure on the uh, bodily structures. Okay. So what are the burn treatment guidelines?
We will code based on a percentage of body involved and the
Yes.
depth.
Yeah, perfect. So we'll code based on the percentage of body surface involved and depth of the burn. Okay. Next, what is the distraction versus debridement versus excision? So distraction means ablation of benign or pre-malignant or malignant tissue by any method, with or without curement. Okay, and distraction does not need any type of repair. Excision needs repair or not?
Needs repair.
Need.
Needs repair.
Needs repair. So debridement needs repair or not?
Yes.
No.
Yes.
Yeah, no need for repair to debridement. So in the operative report, if you are confused, you need to code based on repair also. If you are confused whether physician has performed excision or distraction, you need to check for repair. If the patient performs repair, we can use excision. If the patient does not use repair, we can use distraction or debridement. So what is cryosurgery? What is cryosurgery? Cryo means
Cold.
Cold.
extreme cold. So basically cryosurgery is also a one type of distraction procedure. Okay, where patient will use the extreme cold in order to distract the damaged tissue. Okay, that is the definition. So what do you know about most micrographic surgery?
It's done for skin cancer.
Okay, and
And 100% margin is removed.
next,
And it is coded based on blocks, stages.
okay, next,
And we'll use flap or graft.
yeah. So after performing the most procedure, if the patient uses the repair flap or graft, we need to code it separately. So next question. So when do you use biopsy separately along with Mohs surgery?
If the biopsy is done before the procedure, then we will not code separately. If the a biopsy is not done and it is going to be done after the procedure, then we'll code separately.
Yeah, perfect. So if your biopsy is, for example, today is the June 8th. Okay. So patient came into the hospital and he is having the cancer type lesion. So patient has performed the biopsy, and as soon as biopsy, patient has performed the Mohs surgery. Here we will code the biopsy. So the here important thing is we need to check it is simple. If the patient does not have any type of previous biopsy, we will code biopsy separately. Okay. Please all of you mute. If the patient is having the prior biopsy, we can't code biopsy separately. Please mute yourself. Who is that? So next, you got now? How do you? What are the most surgery guidelines? For most surgery, most of the time, patient will perform for skin cancer. So second guideline is in order to code most surgery, same physician needs to act as a surgeon as well as the pathologist. Okay. Next, along with the Mohs surgery, if the patient performs any type of repair graft, we need to code it separately.
Your voice not
Okay.
audible, bro.
Oh, pectoralis minor. Sorry, pectoralis major. Which one you will use?
307, 19307.
Yeah, perfect. Okay. So what is the difference between 19120 and 19300?
300 is for gynecomastia.
Like otherwise you will call it as like this. So what is the difference between 19120 and mastectomy?
19120 is just cyst, excision
Yeah,
of
perfect.
cyst.
Yeah. Excision of the lesion or cyst. So
The
in
total
mastectomy procedure, yeah,
full removal of the breast.
breast tissue, correct. So 19120 and 19125 are for removal of the lesion of the breast. Okay. So these mastectomy procedures are removal of the breast tissue, not only lesion. Patient will remove breast tissue also. Okay. So whenever if you are confused about whether I can I code 19120, 19125, 193 like mastectomy code, what do you check, guys?
Whether it is a
You need,
tissue or
Lesion.
yeah, yeah,
lesions.
in the yeah, perfect. So you need to check the medical necessity. Why physician is performing this procedure? Whether physician is removing the breast, breast lesion, or whether he is removing the breast tissue. Or most of the time, na physician will perform this mastectomy for breast cancers. You need to check the PDX. Why physician is performing this procedure? Okay. So, what is breast reconstruction?
After mastectomy, they will implant.
Yeah. So basically, after performing the breast mastectomy, physician will close the defects in order to cosmetic appearance. Okay. So that is the breast reconstruction procedure in order to close the defects after mastectomy. Okay. So what are the techniques to code breast mastectomy defect?
Implants are used.
Implant placed,
Yeah,
autologous placed.
yeah. A physician will use the implants as well as flaps. Okay. So what is mastopexy?
Fixation of the breast.
Position.
Yeah. So what is the difference between breast reduction and breast augmentation?
Reduction for reducing the breast, augmentation for to increase the breast size.
Yeah, perfect. Okay. So how do you code if the patient performs removal of tissue expander with placement of breast implant?
Breast augmentation.
Only implant.
So you will code 11970. Okay. So and here also one more. What is the difference between tissue expander and breast implant?
Tissue
Tissue
expander is
expander only
temporary.
for temporary purpose.
Okay. So as soon as and during the mastectomy procedure, as all of us know, physician will remove the breast tissue, correct? Okay. So in order to expand the breast tissue, as soon as physician perform mastectomy, he will perform the or insert the tissue expanders, which will increase the breast tissue or it will enhance the size of the breast. So after enhancement of the breast tissue, physician will remove the tissue expander and he will insert permanent implant. Okay, so that is the difference. So what is the difference between 19340 and 19342?
340 for initial breast implant, 342 for replacement.
Yeah, insertion or replacement. So basically 19340, for example, today is June 8th. Okay, so today physician will perform the mastectomy and he will insert the implant. So that time you will use 19340. So today is June 8th and physician will tell the patient that I will insert the implant on June 15th. So what do you code, 340 or 342?
342.
342.
Yeah, yeah, perfect. 342. So what is tram flap?
Transverse rectus
Transverse.
abdominis myocutaneous flap.
Yeah, transverse rectus abdominis myocutaneous flap. Okay. So what is supercharging in the breast procedures?
Single pediclet flap like
No. So basically, along with the tram flap, if the patient performs separate microvascular anastomosis. So after performing the mastectomy, along with tram flap closure reconstruction, patient performs separate microvascular anastomosis. You need to call it a supercharging. Okay. So what is the difference between capsulorrhaphy and capsulectomy? Or capsulotomy? So basically, so breast is having the capsule. Okay. So as soon as patient will perform this breast implant after few days, everyone will get the capsule around the breast implant. So if the patient performs incision on the capsule, we will call it as capsulotomy. If the patient performs repair of the capsule, we will call it as capsulorrhaphy. And if the patient removes capsule, we will call it as capsulectomy. It's simple. Okay. So what is the difference between 19370 and 19371? So we will use 19370 if the patient performs revision of the peri-implant capsule. What is peri-implant?
Already.
Yeah, surrounding the breast. Okay. Next, yeah, fine. So any doubt, guys, here? So these are the most important questions they will ask in the muscular like integumentary system. Okay, mostly I have covered 90%. I think you might have observed during your interview also. So, do you have any questions other than this, guys, from integumentary system? So, anyone can tell. Do you have any other questions other than this?
No.
Ashwini
No.
and Renuka.
No.
So, same questions they have asked, na?
Yes.
Yeah. Okay, then. So, we will go to musculoskeletal system now. So, what is the largest bone in the body?
Femur.
Femur,
Yeah, perfect. Femur. What is the smallest bone?
ear bones, incus stapes.
Yeah, yeah, stapes, ear bones. Okay. So, what are the spinal levels in the body?
Cervical, lumbar,
Cervical, lumbar,
thoracic,
thoracic, and
Yeah,
Sacrum
cervical,
coccyx.
thoracic,
thoracic,
lumbar, sacrum.
lumbar, yeah,
Sacrum coccyx.
sacrum and coccyx.
Okay.
Okay. So, what are the fused spine in the body?
Sacrum and coccyx.
Yeah, perfect. Sacrum and coccyx.
Fuse
Okay.
9.
Yeah. What is mandible?
Jawbone in face,
Yeah. What is maxilla?
like the
Upper side of lip.
cheekbone in face.
Yeah.
See,
So maxilla is the uh, top portion of the mouth, and mandible is the lower portion of the mouth. Among maxilla and mandible, which is movable?
Mandible.
Maxilla, na? So mandible is fixed. So you can open mouth means you are taking your maxilla up.
Sir, mandible is coming.
Yeah. Okay. So where do you find sternum?
Middle of
in chest area, thoracic.
rib.
Yeah,
Ribs,
rib
chest
area.
area.
Yeah, ribs. Okay. So what is the difference between metacarpals and metatarsals?
Metacarpal hand
Metacarpal.
bones. Metatarsal foot bones.
Yeah, perfect. Metacarpal and bones, metatarsals,
Foot.
foot bones. Okay, fine. What are the lower leg bones?
Femur, tibia, fibula.
Yeah, perfect. In leg also we are having upper leg and lower leg. Upper leg contains femur, lower leg contains tibia and fibula. So anatomy is sometimes important here. So next, so what is the difference between vertebral segment and vertebral body? What
Segment.
is the difference?
Different bodies.
So vertebral body is the part of the spine or rounded portion of the spine. Okay. Vertebral segment is the vertebral body plus spinous process plus transverse process. Okay. So vertebral body part of the spine or vertebral segment is the vertebral body plus transverse process plus
Spinous
spinous
cord.
process. Okay. So what is interspace?
between two segments.
Yeah. Okay. So what is the difference between interspace and intervertebral disc? Yeah, simple. Basically, space means gap between two vertebrae. Okay. So disc means, so non-bony structure in the spine is intervertebral disc. Bony structure is vertebral body or vertebral segment. So non-bony structure is disc. Bony structure is vertebral body or vertebral segment. Okay. So what is interspace? The gap between two vertebrae or the space between two vertebrae.
Vertebra.
Yeah. So next, what is a tendon?
Muscle to muscle. Yeah, yeah. Membrane between muscle to muscle.
Yeah. So tendon will connect.
Muscle to bone.
Yeah. Muscle to bone. Perfect. What is a ligament?
Bone to bone.
Yeah. Perfect. Okay. Now we'll see fracture guidelines. So Fishney has performed the musculoskeletal system procedure on June 1st. Along with Fishney has applied the splint. How do you code this scenario? Single code or multiple codes?
Single code.
Single code. Just here the key thing is initial application of splint or cast are included in the fracture repair. You can't code separately. Okay. So Fishney performed the fracture repair and applied the splint. Physician B removed the splint. Will you code separately or not? Yeah, you need to code it separately. Okay. So Physician has performed like fracture repair and splint application on June 1. And June 7th, patient came in for, so patient had the, again, he fall and again fractured the splint. June 7th, patient came in for again replacement of the splint. Will you code it separately or not? Why means? Here patient is still in the global period. Will you code it separately or not?
No.
Replacement of like cast or splint.
We will not go
You will code separately.
because
So
you got again
subsequent,
fracture. That's why.
yeah. So same location, different location or same location, you need to code it separately. So subsequent replacement of cast, splint or strapping and a traction device during or after the global period. You need to code it separately. So that is CPT guideline, not our guideline. Okay. So along with musculoskeletal system procedure, when do you code graft separately?
It is the same incision was made for repair and grafting. We should not.
Yeah, perfect. So along with the procedure, if the patient uses the separate incision only, we need to code graft separately. Otherwise, we will not code graft. Okay. So what is the difference between fracture and dislocation?
Fracture is bone breaking. Dislocation, uh, the deviation from the anatomical side. Bone.
Yeah, yeah, perfect. So fracture is the break in the bone. So dislocation is the fault location of the bone. So where do you find these locations mostly? In the joint
Humerus.
area. Yeah,
Joints.
joint area. Okay. How does these fracture repair courses are divided? So tell me, what are the approaches for fracture repair?
Percutaneous, open, and
Closed.
Yeah. So what is the difference?
in percutaneous there will be no incision, but in open they'll make an incision.
Okay. Closed? What about closed?
Closed also there is
No
no,
Directly we
incision.
but in percutaneous there is a pins or screws like that. Something will be used.
Flying cast
Ye-
and all.
Yeah. So during the closed procedure, patient will not perform any type of incision. Directly he will use the imaging and he will identify the fracture location. Okay. Whereas in percutaneous approach, patient will insert the, he may create small incision, not big. Okay. So through that incision, patient will insert the screws or pins. Okay. For sometimes you might be confused whether it is percutaneous or open. So how do you identify, guys? So if it is percutaneous, na, patient will create the incision and he will not perform any dissection or cautery. Okay. If it is open procedure, patient will use the scalpel, he will create the incision and he will dissect the tissue. So that is the difference between percutaneous and open. Okay. Next. What is manipulation?
Reduction.
the provider will do manually the fixation and
Yeah.
traction method.
Yeah. So basically, manual application of force is called as manipulation. Okay. So how do you code if the patient performs re-reduction? Okay. How do you code? So patient has performed the initial reduction process and with that reduction, the fracture is not aligned properly. Okay. Again, patient performed a reduction. How do you code?
It's 76 modifier.
Yeah. So repeat procedural service. Okay. So next. So what is the difference between 59 and 76?
66
76 for
and
repetition.
76 is the repeated procedure by same physician.
Yeah. So in 59, you will find two separate CPT codes.
Yes.
Okay. In 76, will you find
Same
same
procedure.
CPT or different CPT?
Same.
Same CPT.
Yeah. So that is the difference. So what is traction?
One of the manipulation technique, provider will track and fix the bone in anatomical cell.
Yeah. So the application of a traction force. Okay. So what is the what is skeletal traction? So if the operative report contains, if the patient tells that, so I have inserted the pin into the bone and I have performed the traction. So skeletal traction. So second way is if the patient performs only application of strapping, we will call it as skin traction. Okay. So that is the difference here. So what is external fixation?
Cast and
Okay, fine.
screw.
So basically after performing the procedure, patient will apply the external fixation device. So based on the patient's condition. In external fixation, we are having two types of fixations, uniplanar and multiplanar. Uniplanar means single side external fixation. Multiplanar means multiple side external fixation device. Okay. So when do you code external fixation device? So basically, whenever you want to code external fixation device in the operating report, you need to check whether physician is performing application of external fixation device or not. Okay. So if the patient performs external fixation device, you need to check the code description basically. If the code description does not have any type of external fixation device application, you will code separately. If the code description is having including external fixation, you will not code external fixation separately. So that is the difference. So what is the difference between integumentary excisions and musculoskeletal excisions?
Repair based on repair. In musculoskeletal only we go complex.
So how do you differentiate skin excisions and musculoskeletal excisions?
Skin level superficial, then it is integumentary. If it is a deep muscle, then musculoskeletal.
Yeah. So in the operative report, if you see subcutaneous tissue, so epidermis and dermis, you can code from integumentary section. If the physician performs excision below epidermis and correct, epidermis and dermis, you need to code from musculoskeletal section. So what is the difference between excision and radical resection? So during the excision process, physician will remove only the diseased area. Okay. In the radical resection process, physician will remove diseased area along with the
Margins.
normal tissue. Yeah, margins are normal tissue along with the defect. That is the radical resection. What is wound exploration? So basically, wound exploration means examination of the wound. Okay. So what is the difference between trigger point and trigger finger?
Trigger point will do in muscles.
Weakness of muscle trigger.
Yeah.
Muscles.
Okay. What about trigger finger? Both are same or different?
It's a bended finger.
Nodules on tendon in
Yeah.
trigger finger.
Yeah. So basically, trigger points are the muscle, weak points on the muscles. Okay. And we will code trigger point based on number of muscles. Okay. So trigger finger is the contracture of the tendon. So it will not move properly. Tendon. Okay. So that time physician will create incision on the diseased area and he will remove the tendon or ligament, or he will incise on the trigger finger area and he will release the pressure or contracture. So that is trigger finger. So what is arthrosynthesis?
Aspiration of fluid from the joint.
Okay. So how do you code if the patient performs arthrosynthesis and injection at same location? Single code, multiple codes.
Single cord.
Okay. So what are the guidelines related to arthrosynthesis?
Based on the joints, we will need to code
Okay.
with
Next.
the guidance also.
Yeah, perfect. So whenever you want to code arthrosynthesis, you need to check type of joint, whether it is small, intermediate or major. Next, you need to check the ultrasound guidance. Okay, it's simple. Okay. So multiplan here they will not ask anything. So what are the types of bone grafts we have?
Three types.
Atolo.
Yeah. So we are
So
having two
hollow
types of
and
bone graft.
xeno.
Sorry,
Autograft, allograft, and xenograft.
those are skin graft, not bone grafts. Don't get confused. Those autograft, allograft, all are skin grafts. So just try to remember skin graft is different, cartilage graft is different, bone graft is different. Okay, so bone grafts are two types. Minor are small, major are large. Simple. Okay. What is replantation? What is replantation?
It's from bone is
So
amputated.
basically, yeah.
For amputation, we will do reimplantation by
it's- So basically, just you can think like that reattachment. So for example, patient is having any type of uh, like uh, like amputations. Physician will again perform the reattachment. These are most of the time due to trauma. Okay, replantation, reattachment, simple. Okay, so what is the difference between morselized and structural graft? Or otherwise, what are the graft you will encounter in the spine procedures?
Mm.
bone graft, cartilage graft, and fascia graft.
No. In
Tendon
spine
also.
procedures, we are having only two types of grafts, allograft and autograft. Okay. Again, they are divided based on the shape of the graft, morselized and structural. So, morselized graft means here physician will take the allograft and he will make the bone graft as like small paste or powder type. So, that one you will call it as morselized. If the physician uses single sample or single structure for bone grafting, that one you will call it as structural graft. Okay. This is very important. Morselized means
Powder.
bone graft in the form of powder. Okay. So structural means bone graft in the form of single structure. So that is the difference. Okay. So what is sarcoma? So basically it is a tumor. Oma means all omas are tumors, correct?
Yes.
Yes.
Yeah. So next in the neck area they will not ask anything. So how do you code tumor removals from musculoskeletal system? So whenever you want to code tumors from musculoskeletal system, you need to check location of the tumor first. Okay. Then you need to check whether physician is removing the tumor from the subcutaneous tissue or subfacial or intramuscular. Why means and next criteria is size of the tumor. So three criteria: location of the tumor. Okay. So depth of the tissue, patient removed the tumor, whether it is subcutaneous or intramuscular, or location of the tumor in the structure, and size of the tumor. So this is the three criteria we need to follow. Next, okay. So what is arthrodesis?
Fusion of the joint.
Fusion.
So what happened during the fusion? So basically during the fusion process, so basically fusion is the very common procedure in musculoskeletal system. Using the fusion process, fusion will stop the movement of the joint. Okay. So by like limiting the movement of the joint, patient will reduce the, or patient will get less pain. In order to reduce the pain, patient will perform the fusion. Okay. What are the steps you will follow for arthrodesis? So whenever you want to code arthrodesis, first you need to check medical necessity. Why patient is performing this procedure, whether it is for herniated disc or whether it is for congenital deformity like kyphosis, all those things. Why means we are having two sets of codes. Okay, so one is for this one, like what do you call congenital deformity or normal deformity, and one is for due to herniated disc. Next, you need to check how many interspaces physician will perform discectomy. Okay, and next you need to check whether physician used the allograft or autograft. Okay, next you need to check whether physician used any type of like what do you call cages. Okay, next you need to check whether physician used muscularized graft or structural graft. Okay, next you need to check whether physician used any type of instrumentation like anterior or posterior instrumentation, and you need to check whether how many segment physician has performed the instrumentation. So these are the steps you need to follow while coding arthrodesis. Okay, what is vertebroplasty?
Surgical repair of a vertebra.
Yeah, so basically vertebroplasty is the process of injecting material into the vertebral body to reinforce the structure of body using imaging guidance. Okay, so vertebral augmentation, what is vertebral augmentation?
They increase the vertebral
Yeah, so
height.
basically, yeah, the purpose of vertebroplasty and vertebral augmentation is same. Okay, reinforce the structure. During the vertebroplasty, physician will insert the needle and he will inject the cement. During the vertebral augmentation, first physician will create the cavity, and after creating the cavity, physician will inject the cement. So that is the difference between vertebroplasty and vertebral augmentation. Okay, what is sacroplasty?
Repair and sacrum.
Yeah, so repair of the sacrum using this one. What do you call cement? Okay, and arthrodesis, one more key thing is approach. You need to check the approach also. So we have discussed correct 6 or 7 points previously. So along with the spine, you need to check the approach also, whether it is Anterior approach, posterior approach, or lateral approach? Okay. So what is carpectomy? So removal of like bone in the spine is called as carpectomy, or bone in the vertebrae is called as carpectomy. So what are the guidelines related to carpectomy? So in the cervical spine, if you want to code for carpectomy, patient needs to remove more than 50% of the cervical spine. So that time only carpectomy you will code. For thoracic and lumbar, patient needs to remove
33%.
greater than or like more than 33% of the spine. Okay. So patient performs 40% of the cervical spine. Will you code carpectomy or not?
No.
No.
So what do you do if the patient does not mention anything related to this? For example, in the documentation, you will see patient tell, I have performed the carpectomy of the cervical spine, but he will not mention anything. Will you code carpectomy or not?
We'll query the provider.
Yeah, perfect. So based on your client requirement, you will query the provider. Otherwise, if the based on your client, you will not code any carpectomy. Okay. So okay, guys. So after the disconnection of this session, please take 5 minute rest break and come again. So we will complete this batch today. Okay.
Okay.
Okay, that is the thing. You can join again. So that is the guideline. So those are the carpectomy guidelines. 50%, more than 50% bone removal in the cervical area, that greater than 33% bone removal in the thoracic and lumbar. Okay. So what is spinal instrumentation? So after performing the arthrodesis using the bone graft or intervertebral device, patient will use the instrumentation. Okay, so that is the spinal instrumentation. We are having two types of spinal instrumentation, segmental or non-segmental. So segmental means fixation at each end of the construct and at least one additional interposed bony attachment. Okay. Non-segmental means it will have proximal hook and distal hook. So segmental, you will find proximal hook, distal hook, and in the middle also you will find the hook. So that is the difference between segmental and non-segmental. So I think what are the components of shoulder?
Facies joint.
Okay. So shoulder consists of clavicle, scapula, humerus head and neck, sternoclavicular joint and AC joint. Okay. So all of you need to join after this session. So I will not take repeat class for new batch. Okay. All of you need to join. What is osteomyelitis? Inflammation of the bone or infection of the bone. So what is the difference between arthrotomy and arthroscopy?
Scope is for to examine that.
Okay.
Arthrotomy
So
is surgical opening.
yeah. So basically, wherever you see intra-articular or arthro means related to joint. So arthrotomy means incision on the joint. Arthroscopy means examination of the joint. So that is the difference. So what is the arthroplasty?
Surgical
Repairing, I mean, joint.
joint.
Yeah, replacement of the joint basically. Okay. In arthroplasty, for example, if you take shoulder, physician will replace the glenohumeral joint. Okay. So what is total shoulder arthroplasty? What are included? So in shoulder, we are having hemiarthroplasty. So in hemiarthroplasty, physician will replace only glenohumeral joint. Okay. In the total shoulder arthroplasty, physician will replace glenoid and proximal humeral replacement. So where do you find glenoid cavity? On the scapula area. Okay. So what is revision of total shoulder arthroplasty? So basically during the revision of total shoulder arthroplasty, on the scapular area, physician will fix the humeral component. Okay. On the humeral area, physician will fix glenoid component. Just making the reverse. That you will call it as revision. So next, these are enough. So what is bunion? Where do you see bunion?
Heel.
In big toe,
Yeah, perfect. So bunion is the abnormal angulation of big toe. So what is the difference between bunion and bunionity? So you will see bunion on the big toe, bunionity on the small toe. So that is the difference. So next here they will not ask anything. So how do you code bunionectomy? So first, what is bunionectomy?
Surgical removal of bunion.
Yeah. So bunionectomy is the process of removal of the bunion. Okay. So whenever you want to code bunionectomy, few things you need to remember. So first one is location of the osteotomy. Okay, whether patient is performing osteotomy on the uh, proximal side or distal side. Okay, based on location of osteotomy, you need to code bunionectomy procedure. So that is the guideline. So next, what are the components included in hip arthroplasty? Like shoulder, here also acetabular component as well as femoral component included in hip arthroplasty. Okay, and here you are having one more extra code. If the patient performs any type of previous hip surgery into total arthroplasty, we are having separate code 27132. Okay. So whenever you code this arthroplasty, hip arthroplasty, you need to check medical necessity whether physician is performing for osteoarthritis or any type of fracture. Okay. So based on that, you need to code. So whenever you code, you need to check in the operative report how many, whatever it is, whether it is shoulder, knee, or hip.
Starting point is femoral artery and then aorta. If you crosses the aorta, then it's selective.
Yeah, perfect,
And
perfect. So if it does not crosses,
Non-selective.
then it's non-selective.
non-selective. So what is the difference between AV graft and AV fistula?
AV fistula is anastomosis between artery and vein.
Perfect.
And in AV graft, there is a graft used between artery and vein.
Yeah, perfect. Yeah, correct. So what is the difference between tunneled and non-tunneled catheter? So basically, tunneled means,
For
anyone knows?
permanent,
Yeah, go ahead.
permanent and non-tunnel means at temporary catheter.
Yeah. So we can't decide based on that. Whenever you want to code, we need to check the operative report basically. So in the tunnel catheter insertion, physician will create an incision and he will place catheter beneath the subcutaneous tissue. Okay, so that one you will call it as tunnel catheter. Sometimes you will see keyword as I have performed tunneling. So tunneling means you need to consider it as tunnel catheter. Okay, so next one is non-tunneled. So where physician will insert catheter on the superficial. He will not go below the subcutaneous tissue. So directly he will connect like catheter into the artery or vein. Okay, so that is the non-tunneled. Okay, so any doubts from respiratory and this cardiovascular? Okay, fine. So what is digestive system and its components? So digestive system consists of oral cavity, esophagus, stomach, okay, small intestine, a large intestine, rectum, and anus. Okay. So our digestive system consists of two tracts, upper gastrointestinal tract and lower gastrointestinal tract. So upper gastrointestinal tract procedure includes EGD, most commonly EGD, and esophagoscopy. Okay. So lower gastrointestinal tract procedure consists of sigmoidoscopy and what is the other one, guys?
Colonoscopy.
Perfect. So sigmoidoscopy and colonoscopy. What are the parts of UGI? So oral cavity to duodenum or jejunum. Okay. What are the parts of lower GI? Anus to ileocecal wall. Simple. So what is full form of EGD?
Esophageal
Duodenoscopy.
So what is the difference between esophagoscopy and EGD? Simple, correct. So esophagoscopy means physician will examine only esophagus. EGD means esophago-gastro-duodenoscopy. Here physician will examine esophagus, stomach
Stomach
and
and
duodenum. Yeah, that is the difference. Simple. Okay, so what is EMR?
endoscopy mucosal resection.
Yeah, perfect. So when do you code bleeding? Bleeding due to endoscopy? So if the patient's encounter is exclusively for bleeding control, you can code. So for example, physician is performing the endoscopy. So during the endoscopy, physician will encounter a small bit of bleeding. So that time you can't code bleeding along with endoscopy procedure. If the patient's encounter is exclusively for bleeding control, you can code it separately. So what is APC? What is the purpose of APC?
Clotting, clotting of blood.
So basically, APC means organ plasma coagulator. So most of the time, physician will use this technique in order to control the bleeding. Simple. Okay. What is EMR?
Endoscopy mucosal resection.
So what are the steps in EMR?
Injection, demarcation, and polypectomy.
Yeah, perfect. So in the operative report, for example, if you see, I have lifted the lesion and I have performed the polypectomy. How do you code?
2 code.
Yeah, 2 code. Why not EMR code?
If 3 are performed, we will code single.
Yeah,
If not 3 means separate codes we have to.
yeah, perfect. So what is PEG tube?
Percutaneously endoscopy.
Yeah,
Gastrostomy.
percutaneous endoscopy gastrostomy tube. So what is ERCP?
Endoscopy retrograde cholangiopancreatography.
Yeah, perfect. Endoscopic retrograde cholangiopancreatography. So what is the difference between antegrade and what do you call antegrade and retrograde? What is antegrade? So antegrade means along with bed flow. So retrograde means against the blood flow. It's simple. Okay. So and your interview like hernia repair also important. So last week I have posted one video related to hernia repair. Please that watch video. Sorry. Please watch that video. Okay. So majorly na just you need to go to our my YouTube channel and you need to check or you need to watch all CPT playlist. Those all are important. Okay. So as I told you before, people are getting jobs by using only my YouTube videos. So just go to CPT playlist and check all the videos. So job is in your hand. How you prepare yourself. So you have all the resources. So you need to put concentration. So what is sleeve gastrectomy? What is sleeve gastrectomy? Yeah, go ahead.
Flow surgery.
Yeah,
Removes the portion of the stomach.
yeah. Yeah. Correct. So just we need to tell them. So sleeve gastrectomy is the bariatric surgery where physician will reduce the intake of the food by excising the stomach. It's simple. Okay, so that is the sleeve gastrectomy. Okay, so what is colectomy?
Removal of the colon.
So how many types of colectomy we have? So partial colectomy and complete colectomy. Simple. So partial means only part of the colon will be removed by the physician. Okay, so complete colectomy means physician will remove complete colon. It's simple. What is colostomy? What is colostomy?
Incision on the colon.
Ostomy, not otomy. Ostomy is different, otomy is different.
Opening into the abdominal wall.
Opening into the abdomen.
So after performing the excision of the colon, physician will create colostomy in order to transfer waste contents outside the body. So here patient will have the colostomy bag outside the body or extracorporeal. Okay, so excreta will go to that colostomy bag. Okay, so what is proctosigmoidoscopy?
Examination of the rectum and sigmoid colon.
Yeah, portion of the sigmoid colon. So what is sigmoidoscopy? This is also same, including rectum, sigmoid colon and portion of the descending colon. Okay, next. What is colonoscopy?
Examination of colon.
Yeah, perfect. Complete colon, like anus to ileocecal valve. Okay, so whenever you want to code colonoscopy, you need to check where is the starting point, whether it is through the anus or whether it is through the stoma. Stoma means artificial opening basically. So you need to check the insertion point, must and should. Otherwise, you will code incorrect code. We are having separate set of codes for colonoscopy through stoma. So that's why. So what is the difference between anal fissure and anal fistula? So basically anal fissure is the tear in the anal area. Okay. So anal fistula is the passage created in between anus and inside the abdomen. So abnormal passage basically. So what do you know about colonoscopic decision tree? So whenever you want to code colonoscopy, you need to check whether physician is performing diagnostic or therapeutic colonoscopy or screening colonoscopy. Okay. So if the patient perform diagnostic procedure, if he does not reach splenic fracture, we need to code it as flexible sigmoidoscopy. Diagnostic flexible sigmoidoscopy. If the patient crosses the splenic fracture but not to the cecum, you need to append 53 modifiers along with 45378. If the patient reaches the complete colon, directly we'll code 45378. Okay. Next, therapeutic colonoscopy. If the patient does not reach splenic fracture, you need to code flexible sigmoidoscopy, therapeutic procedure, not diagnostic. So beyond the splenic fracture but not to the cecum, you need to code colonoscopy codes using 52 modifier. To cecum, you don't need to append any modifier. So what is important here, whenever you want to code colonoscopy, You need to check whether physician is performing diagnostic colonoscopy or therapeutic colonoscopy or screening colonoscopy. So, and already we have discussed the colonoscopy guidelines, correct? Like modifiers. Next, any doubts, guys, here?
In esophagogastroduodenoscopy, when we'll use that 52 and 53 modifier?
So, I think we will check once. So, what is the code? This one? I think we have one guideline related to that. 43239. I think we don't have any guideline related to that. Let me check once in the CPT book. So, did you find any guideline in the CPT book? Yeah, we are having guideline. So, thanks for asking
Yes,
this
we
one.
have
Yeah. So, to report
page
esophagogas where the
356.
duodenum is deliberately not examined or because the clinical situation precludes such exam. Append modifier 52. If repeat examination is not planned. If repeat examination is planned, we need to use 53 modifier. So here the simple way, if the patient does not examine the duodenum due to any type of issue, if the physician wants to perform the repeat EGD, you need to append 53 modifier. If the patient don't want to perform the repeat EGD, that time you need to use 52 modifier. It's simple.
Okay.
Okay. 52 repeat examination is not planned. 53 repeat examination is planned. So what is important here? Whenever you want to code 52, 53, you need to check the operative report. How long physician entered, whether physician reached the duodenum or not. So based on that, you need to code. Simple. Okay.
Okay.
So what is hysterectomy? So already we have discussed. Yeah, one more thing we need to discuss for colonoscopy. So what is the difference between high risk colonoscopy and low risk colonoscopy screening? What is high risk, guys? What are the components of high
If
risk?
person has a family history of colon cancer,
Yeah, and if the patient is having personal history of cancer, we can consider high risk. If the patient is having inflammatory bowel disease or colitis, we will consider it as high risk.
high risk.
If the patient does not have any of these conditions, we will consider it as low risk. Okay. So when do you use this high risk and low risk? In what situation you will use?
In Medicare patients,
Yeah, Medicare patients. If the patient came in for screening colonoscopy, okay, for Medicare patient only. If the if the physician does not identify any abnormality, that time you need to use these codes. G0121 for low risk, G0105 is for high risk. So that is the guideline. Okay. For Medicare patients, you need to use this one. Okay. So in urinary system, mostly they will not ask anything. So what is hysterourethropy? Examination of urethra as well as the bladder. Okay. So how do you code if the patient removes multiple stones?
largest diameter.
Yeah, perfect. So you need to code based on largest diameter. Okay. So what is hysterectomy and what are the types of hysterectomy?
So removal of uterus.
Yeah. So removal of the uterus. Hysterectomy means removal of the uterus. We are having different variants. Sorry. Total hysterectomy, partial hysterectomy, or supracervical hysterectomy. Okay. So in complete total hysterectomy, physician will remove uterus along with cervix as well as fallopian tubes and ovaries. Okay. In the supracervical hysterectomy, physician will remove only uterus as well as the tubes. She will not remove the cervix. So basically, uterus is divided into two parts: uterine fundus and uterine cervix. During the complete total hysterectomy, physician will remove both uterus, like uterine fundus and uterine cervix, plus tubes and ovaries. Okay. Whereas in supracervical hysterectomy, physician will spare the like cervix. He will remove only fundus or fundus of the uterus as well as tubes and ovaries. So that's all. So mostly in the here they will not ask anything. Okay. Just uh, so guys, if it is disconnects, you can join again. Only we are having 15 minutes more. So they will not ask anything. So if it disconnects, you can join as soon as possible. Okay. So next, you need to remember types of hysteroscopy or hysterectomy. So what is the difference between colposcopy and colpotomy? So colpotomy is incision on the vagina. Colposcopy is endoscopic examination of vagina. Okay. So what is the difference between hysteroscopy and hysterectomy?
Hysterectomy is surgical removal of the uterus, and
Yeah,
hysteroscopy is the examination of the uterus.
yeah, perfect. Okay. So you no need to worry. As I told you before, na mostly they will ask from integumentary and from there only. Where? Integumentary, musculoskeletal, digestive. So what Ashwini, is that correct or not? Ashwini and Renka.
Yeah. Yes.
Yeah, they will not ask from only those. Okay. So nervous system also they will not ask more. Just they will ask approaches. What is ESI? So what is ESI, guys?
Epidural steroid injection.
Yeah, perfect. What is TSESI? TFESI, sorry. Transforaminal steroid injections. Okay. Next they will ask facet joint injections. So same guideline they will ask. So how do you code this one? Like for example, physician performs two joints, two vertebral joint, facet joints. For example, if you see in the operative report, L2, L3, L4, L5. So how many facet joint injections you will code?
2.
3. L3 to L3, one facet joint. L3 to L4, another facet joint. So L3 to L5, another one. So total 3 facet joint. Okay. Whenever you code facet joint, first primary you need to code primary code. For other codes you need to code, you will not append 50 modifier to facet joint injection. You need to code separately along with RT and LT modifiers, which we have discussed already. Okay. And next, so that's all. So what is neurostimulator and what are the components of neurostimulator? So neurostimulator is the device which will stop or block the signals to brain. Okay. So neurostimulator consists of pulse generator, extension lead, as well as the extension wire, as well as the lead. So we are having three types of neurostimulator: intracranial, spinal, as well as peripheral neurostimulator. Okay. So what is the difference between complex cataract and simple cataract? Anyone knows, guys? If the physician uses like trypan blue or any type of uh, like posterior capsulorrhaphy or intra-articular supporting device. Sorry, not intra auricular. Sorry, iris expansion device. So we will call it as complex. If you don't see these keywords in the operative report, you need to code it as simple cataract. That's all. Okay. So what is CSF?
Cerebrospinal fluid.
Cerebrospinal fluid.
Yeah, correct. What is VP shunt?
Ventriculoperitoneal shunt.
Yeah. So when does physician will use ventriculoperitoneal shunt?
When there is a hydrocephalus.
Yeah, perfect. So in order to drain, so cerebrospinal fluid or any type of hemorrhage from brain to the like peritoneal cavity, physician will use this shunt. Okay. So next we have completed from this area. So any doubts, guys? So what is hemilaminectomy? What is the other name for hemilaminectomy?
Laminotomy.
Yeah, perfect. So other name for hemilaminectomy is laminotomy. Okay. So when do you use KX modifier? Okay. So KX modifier you will use if the services
Threshold
are
of
exceeded certain threshold. So threshold means number of times basically. Okay. If the services exceed uh, finalized thresholds, we need to use KX modifier. Okay. So when do you use KX modifier in colonoscopy? Okay. So the KX modifier used to indicate that a screening colonoscopy was performed as a follow-up to positive result from a non-invasive stool-based rectal cancer. Okay. So for example, physician has performed non-invasive stool test for colorectal cancer screening. Okay. So that time, so basically patient came into the hospital. Okay. So physician has performed non-invasive stool-based colorectal cancer screening. So during that screening, if the physician identifies any type of positive result, you need to append KX modifier. So you will use this KX modifier along with G0105 as well as G0121. Only along with these Medicare patients only you will use this KX modifier. Okay. So next we are having few important questions. I think mostly we have discussed all. So we have discussed EMR. Okay, we have discussed arthrosynthesis. Okay, so we have discussed denial reason. So what is ECMO? So
Artificial
extra,
lung machine like extracorporeal
yeah, perfect. Extracorporeal membrane oxygenation.
vaccination.
Basically, here you need to remember extracorporeal means outside the body. So if it disconnects, you can join, please. Okay. So extracorporeal means outside the body. Corpora means body, basically. Extra means outside. So outside the body, you will call it as extracorporeal. Okay. So what is the difference between selective and non-selective debridement? So selective means if the physician removes specific targeted areas of viable tissue, non-viable tissue, okay, you will call it as selective. Non-selective means non-surgical debridement using the brushing or irrigation or scrubbing. Okay, so that is the difference between selective and non-selective. So next, nothing. So we have discussed incision and drainage. So what is the difference between so PICC line and CVC line?
CVC line central venous catheter.
Okay,
Uh, PICC line is peripherally inserted.
yeah,
It's
correct.
like
Yeah. So PICC line is a central catheter. So basically PICC line is also a central venous catheter only. So based on the insertion site, we need to decide whether it is PICC line or CVC line. Okay. So PICC line most of the time physician will insert or access point is peripheral vein in the arm, and it will insert the central veins near the heart. Okay. So central veins physician will insert catheter in the which area, guys? Neck area, like internal jugular vein. Okay. So if the patient access point is in the neck area, you will code it as CVC line. If the access point is in the arm or leg area, you will code it as PICC line. Okay. So we have discussed most surgery guidelines. So TC 26 we have discussed, correct? TC
yes.
and 26 modifiers.
Yeah.
So we have discussed
Yeah.
catheterization guidelines, selective and non-selective. So can we code most surgery along with biopsy? Yes or not?
If the same day means we can code.
Yeah, perfect. If there is no prior biopsy result, we can code. If there is prior biopsy result, we can't code this procedure. Okay. So we have learned 51 and 59 colonoscopy complete. So what are the nephrectomy types, guys? What are the nephrectomy types? Okay. So nephrectomy, we are having three types of nephrectomy. Okay. So partial nephrectomy, it will remove the diseased portion of the kidney. Okay. So radical nephrectomy, here physician will remove complete kidney along with the surrounding fatty tissue. Okay. So donor nephrectomy, which is used for donor purpose. If the patient's relative will give the donation of the kidney to the patient, we will call donor nephrectomy. So partial, radical, and donor nephrectomy. Okay. So we have learned pacemaker and defibrillator. So now you know CVAC and peripheral inserted catheter, correct? So you know complex repair guidelines. You know complex cataract surgery. Okay. So you know complex incision and drainage. Complex cataract surgery, fine. 51, 59, you know. So what is the difference between 78 and 58, guys? What is the difference? 78 and 58. So can you hear me or not?
Yes.
Yeah, okay. Thank you.
Un-
58 is stage-wise
78 is
procedure.
unplanned and
Deleted.
58 was related procedure
Yeah,
in the
perfect.
same position.
Yeah. So 70 is unplanned return to the OR room for related procedure. So 58 is staged procedure. Okay. So basically pacemaker defibrillator we know. So we have learned all these things. Okay. Global surgery, 0 day, and so okay guys, mostly we have completed all. So any doubts for you?
No.
So
So
today's videos you will share to us, right?
yeah,
Maybe?
yeah,
Okay.
yeah, of course. So see, frankly, if you get the job, I will feel very happy. But most of the students are getting. So basically, all these questions got from those students only. So now also, if you go to any interview, if you are unable to find the answer, please let me know. I will try to help you. Don't keep it with you. Okay. So I
Okay.
think
Sure.
we are having few more things. Final fusion. So what is non-union and mal-union?
Small
Non-union.
union is the like the position, the bone structure is malformed. Like after the treatment, the bone will be
Bone will be in the abnormal position or
abnormal
location.
position.
Okay. Non-union means
Improper fusion of the joint after fracture.
no. That is the definition for malunion. Non-union means there is no union between the
Ah,
bone.
yeah.
Okay. So what is LCD and NCD?
LCD local coverage determination and NCD national coverage determination.
Yeah. For example, if you are having both LCD and NCD, which one is supersedes?
And
LCD.
Yeah,
LCD.
NCD. Correct. So what is the purpose of these CDs? LCD and NCDs? So basically, LCDs and NCDs are related to medical necessity. Okay, CMS will publish this. LCDs are related to each state. So state-wise are LCDs. Whole country is NCDs. National coverage determination and local coverage determination. Okay. So we have learned nephrectomy, global surgical package, 74 complete, cardiometer. What is angiography?
Repairing heart wall.
Graphy.
Is graphy. Okay.
Examination.
Yeah. So examination of the vessel,
Examination.
blood vessels basically. Okay. So what is IVR? So IVR is interventional radiology. Okay. So how many types of IVR we have? So we are having two types of IVR. Okay. Vascular and non-vascular. So vascular IVR related to blood vessels. Non-vascular IVR related to other than blood vessels. Okay. So what are the components of IVR? So the components of IVR includes procedure as well as the imaging guidance. Okay. Mostly, for example, if you want to code, a vascular procedure, you need to use 30,000 series as well as the 70,000 series. So IVR is a two component procedure. So first component is surgical procedure, second component is imaging guidance. Okay. So what is a vascular family? What is vascular family, guys? So most of the time we will use vascular family for interventional radiology coding. Okay. We are having two types of vascular families, arterial as well as venous. Okay. Again, arterial vascular family divides into two types, abdominal aorta as well as thoracic aorta. And this vascular family again divides into families like first order, second order, and third order. Okay. So after the third order, you will call it as super selective. Okay. So in the operative report, if you see super selective catheterization, you need to use third order only. Okay. In arteries, we are having three orders: first order, second order, and third order, and super selective. In the venous IVR, we are having three orders: first order, second order, and super selective second order. So in vein IVR, we don't have third order, only first, second, and super selective. Okay. So for IVR also in my YouTube channel, you are having few videos. Check IVR IVR playlist. Okay. So most of the things we have discussed already. So these are the most important concepts for your what do you call interviews. So I have segregated. I have what do you call collected all these Q&A, and I have used these for my these things. What is pain management?
To reduce or to stop the pain, you give injections.
Yeah. So basically to perform the reduction of the pain, physician will perform pain management using steroid injections as well as pain management mission also there we are having. Okay. What are the cardiac catheterization steps? What is cardiac catheterization first? What is cardiac catheterization?
Catheter will
So
be inserted.
yeah. So basically cardiac catheterization is the process of examining the coronary arteries. Okay. So based on the necessity, along with the diagnostic procedure, physician will perform therapeutic procedure also. Initially, physician will start diagnostic. If physician finds any type of so any type of procedure, we need to code it as therapeutic procedure. Okay, we are having three sets of code sets: right heart cath, left heart cath, as well as both right and left heart. Okay, for right heart catheterization, your access point is veins. Okay, for left heart catheterization, access point is artery. Okay, so these are the things you need to tell. That's all. Okay, just they will ask the definition. What is cardiac catheterization? So what is disarticulation?
What, David?
Disarticulation.
sir.
It's a type of limb amputation.
Yeah, correct. So where physician will not perform any excision. Okay. So here physician will perform removal of bone from the joint basically. Okay. So that is the disarticulation. Disarticulation. So we have learned hysterectomy, polypectomy procedures. Okay. So do you have any doubt about polypectomy?
No.
Okay, clear. Okay, so if you are having any doubt in the future, send me the message. Okay. So when do you use silver nitrate in CPT?
For debridement, burn related.
Yeah. So most of the time you will use this silver nitrate for cauterization. Okay, or sinus or fistula. So types of hysterectomy we learned, polypectomy we learned. Okay. So how many types of snare polypectomy we have? What is snare polypectomy? First tell me. So we will use snare polypectomy in
By
colonoscopy.
using
To remove the polyps.
Yeah, correct. Okay. So where during the colonoscopy, physician will use so like snare device and he will remove
Polyps.
the polyp. Okay. So what code you will use for cold biopsy forceps? So 45380. Okay. So next, what is this? What is global delivery package?
it is inclusive
It
in
includes antepartum,
preoperative.
prepartum, and delivery.
Yeah, perfect. Yeah, global delivery package includes antepartum during the surgery or prepartum, intrapartum, and postpartum.
Postpartum.
Yeah, okay. Next, what is a trimester?
Gestational period.
Gestational weeks.
Yeah, so trimester is the term we can use in order to denote gestational weeks. So what is the criteria?
Three types of trimesters. Three trimesters there.
Yeah, what is the weeks?
1 to 14 first, 15 to
0
0 to
28
to
14.
second,
0 to
0 to
14.
0 to
14.
14, yeah.
Okay. Next,
15 to 28 is second, 29 to up to
14. No, no,
delivery.
no.
14
It
to
is wrong.
28.
1 second. 0 to 14. Yeah.
14 to 28.
14 to 28.
28.
28 to until delivery. So you can't tell 1 to 15 here. 0 to 14. 14 to 28. 28 to until delivery. Okay.
Okay, then 14 weeks means which trimester? 14
Greater
weeks,
than
5 days.
14. Yeah. So greater than 14. So for example, in the operative report, if you see 14.5, you can't code it as like 15 weeks. You need to code 14 weeks only. You
Yes.
can't do round up basically. Okay. Yeah.
Okay.
What is salpingectomy?
Removal of
Removal of
ovaries,
fallopian tubes.
tubes,
Yeah. What is oophorectomy?
ovaries.
Removal
Removal
of
of ovaries.
ovaries.
Yeah. Perfect. So what are the types of miscarriages? Miscarriage means abortion basically.
Complete,
Written
incomplete, and
Yeah. Threatened abortion, incomplete abortion,
Spontaneous.
complete abortion,
Complete
and missed
abortion.
abortion. Okay, so these are the types of miscarriages. So what is comminuted fracture?
Bones
It
will
is displaced. Like
do things.
So basically, comminuted fracture means more than multiple fragment. If the patient is having any fracture and if the patient is having multiple fracture fragments, we will call it as comminuted
community.
fracture. Okay. So what are the types of NCCI indicators? What are NCCI indicators?
It will be denoted by 0, 1,
0, 1, 9,
Yeah, perfect.
in
0,
column
1,
1,
9.
7,
column.
and 9.
So what is the meaning of 1? Will you append modifier or not? So basically, if the indicator is 0, you can't bypass CPT
Procedures.
procedure.
Yes.
Yeah. If it is indicator of 1, you can bypass using the 59 modifier. Okay. If it is 9, this
It's not
concept is not applicable. Yeah.
applicable.
So those are the guidelines. Okay. So how do you bypass code pair? Using the 59 modifier. Okay. So what are the types of tendons? So basically we are having two types of tendons, flexor tendon and extensor tendon. Okay, extensor tendon you will see on the surface of the skin. For example, if you take hand, top of your hand is having extensor tendon. Palm of your hand consists of flexor tendon. So flexor tendons are useful for flexing the hand. Extensor tendon useful for extension. It's simple. Okay. What are the common fracture types?
Closed and open,
Yeah,
displaced and non-displaced. That.
yeah, perfect. So those are correct. Okay. So next to Banyan we have learned global surgery NCCA date, CPT code, shoulder debridement we have learned, open and closure fracture repair, global modifiers, hernia guidelines. So as I told you, you need to check hernia guidelines in my YouTube channel. Okay. You need to check the 2025 CPT and ICD-10 CM guidelines also. So mostly these are the guidelines they will ask in the interviews. I am checking for any new question. Most of the time we have what is undermining? What is undermining and where do you see undermining?
Under complex repair, we can see that under.
Yeah. So basically, undermining means taking the skin edges nearby in order to perform suturing the. So whenever physician will perform repair, in order to take the edges laceration or repair edges nearby, physician will remove the tissue under the skin. So that is we will call it as undermining. Okay. So what is Hartmann procedure? So Hartmann procedure is for alternative for colectomy. Most of the time physician will perform this procedure on the left colon. Okay, it involves removing colon and rectum. So that is the Hartmann procedure. So what is neurography?
Repair in neuron.
Nerve.
Nerve.
What is angioplasty?
Repair in heart layer. Yes.
Yeah. So basically, whenever patient is having any type of stenosis in the artery and vein, patient will perform angioplasty using the balloon. Okay. So I think like nerve blocks, septum. So I think we have learned all these things. What is fasciectomy? Removal of facet joint. Previously we have learned injections, correct? Facet joint injections. So fasciectomy
Yes.
means removal of facet joint. Okay, next last one. So difference between radical mastectomy, we have learned amputation. Yeah. What is the difference between amputation and disarticulation? So amputation means surgical excision. Okay, disarticulation means like
Heart
removal of,
excision.
yeah, disarticulation, like removal of bone from the joint, or dislocation of removal of this bone from the joint. Okay, so how to code below the knee amputation and above the knee amputation? Combination code or single code? Okay, so here you need to code single code only. Again you will code for amputation. Okay, so previously patient is having the below knee amputation. Now patient came in for above the knee amputation. You need to code single code, not double code. Okay, how to check OP for amputation? So what are the keywords for amputation, guys? What do you check?
Any necrosis, removal of limb.
Yeah, perfect. Any type of incision, excision, so like disarticulation does not comes under amputation. So one type of amputation. So you need to check the operative report and you need to code whether physician has performed disarticulation or complete excision of the joint or bone. Okay. So revision is required or not in fracture repair when we will code. So basically most of the time, so revisions means these only non-union and malunions. So it is required. Okay. So most of the time this non-union and malunions we will encounter during the after the fracture repairs only, correct? So during the
Yes.
revision process, patient will perform this repair of non-union and malunions. Okay. Knee arthroplasty we have discussed, hip replacement, rotator cuff muscles, abdominal wall hernia repair guidelines. You need to check my YouTube channel. Lesion 1 is 5 centimeter, lesion 2 is 3 centimeter. Distance between two lesions gap is 9 centimeter. Single code or separate codes. So here you need to code single code. Okay. So if the gap is more than 10 centimeter, you need to code two codes. If the gap is less than 10 centimeter, you need to code single code. Okay.
It's same for hernia and lesion, right?
So lesions we anyway will code like separately, correct? This
Yeah,
guideline is for
for hernia.
basically, yeah, hernias.
Okay.
Here instead of lesion we need to take it as defect size. Okay. So can't this one name the instrument. So we have one question here. Name the instrument used in the arthro disease. Frankly, I don't know. I need to check Google. Okay, so they are telling here osteotome, curate, bone bars, bone saws, screws and plates and rods. Okay, EMR we have learned colonoscope from anus to descending colon. Colonoscope from. So what do you call colonoscopy from anus to descending colon?
Complete colonoscopy.
Like
Yeah. So colonoscopy from anus to descending colon. What do you code? Physician is performing therapeutic colonoscopy. And how do you code this one? So you need to append. You will code it as
52
sigmoidoscopy.
modifier.
No, 52 modifier you need to use after if it crosses the splenic fracture. Correct. See
Okay,
the
yeah.
tree. See the
Yeah.
colonoscopy tree.
Right. We'll
Yeah.
code flexible sigmoidoscopy now.
Sigmoid.
Yeah. Correct. So how do you code colonoscopy from anus to transverse colon? Now you will use 52 modifier based on type of colonoscopy. If it is diagnostic, you will use transverse colon reached means patient crossed the splenic fracture.
Mm-hmm.
Correct.
Yes, beyond fluent
So
flux.
yeah, beyond splenic fracture. So if it is diagnostic colonoscopy 53, therapeutic colonoscopy 52 modifier. Okay. So anus to ileocecal valve.
No
complete full.
modifiers.
Yeah, complete colonoscopy. Okay. So if two lesions found in transverse colon, combination code or single code. Okay. So if the patient performs, here you need to check the approach. So for example, patient has performed colonoscopy and polypectomy in the same transverse colon. So you need to code single code here. Why means if you check the code description of colonoscopy with polypectomy, they have mentioned S in the code description. Correct or not? So see the colonoscopy code 45385 or 45380. Check once and let me know. So code description consists of S.
Yes, tumors, polyps, and lesions.
Yeah. So here you will code single or multiple codes.
Single.
Yeah. Perfect. Single code. That is correct. Okay. So if diagnostic procedure convert to therapeutic procedure, how to code for Medicare and commercial? So you need to code open procedure. Okay, biopsy, polypectomy. So when do you code biopsy and polypectomy separately? So when do you code, guys? When do you code? So if the patient perform biopsy and one lesion and polypectomy and another lesion, we will code separately. So that is the guideline. Same lesion, you will code only polypectomy. Separate lesions only, you will code separately. Okay. Next, what is endoscopic ultrasound? Okay, so this is 43259. So along with EGD, sometimes physician will perform ultrasound also. EBUS you will call it as. Okay. So EBUS, sorry, only UUS, endoscopic ultrasound. So you will find it in the EGDs. Okay. Lithotripsy and cystourethropy, one code are separate codes. When we'll code separately. Okay. So basically we are having one combination code, lithotripsy and cystourethropy. We are having one combination code 53256, cystourethropy with lithotripsy. So we will code one code. Okay. So you will code separately if the physician will perform lithotripsy in the bladder. and lithotripsy in the ureter. So that time we will code separately. Okay, radical equivalent hysterectomy. So how do you code if you are unable to find uterus size? How do you code, guys? For in order to code hysterectomy procedure, uterus size is the criteria. So if the documentation does not contains, how do you code? Sorry,
Minimum
uterus weight, not size, weight.
minimum weight.
Yeah, minimum weight. Otherwise, based on client, you need to like query the physician. Okay. What is VBAC? So vaginal birth after cesarean delivery. VBAC means vaginal birth after cesarean delivery. Okay. So how to code decompression and what to check in the OP. Okay. So whenever you want to code decompression procedure, you need to check nerve roots and nerves. Whether physician is removing anything in order to release compression on the nerve. Okay. So what is the difference between abdominal hysterectomy and vaginal hysterectomy? What is abdominal hysterectomy, guys? So here approach is abdomen. So physician will remove the uterus through the abdomen. So during the vaginal hysterectomy, physician will remove uterus through the vagina itself. Okay. So okay, guys, these are the common questions mostly you will encounter during your surgery interviews. Other than this, you may encounter other questions also. So if you are unable to answer any question, please let me know. I will provide the answer. Okay. So one more is indwelling catheter. What is the difference between indwelling and non-indwelling? What is the difference, guys?
Temporary and one is interlinked
Yeah,
temporary and another one is permanent.
yeah, perfect. So it is based on the duration of the time patient wants to keep the catheter. So what is Foley catheter then? What type of catheter? Check the Google.
Indwelling.
Yeah, perfect. So Foley catheter is one type of indwelling catheter. Okay. So okay, guys. Mostly we have covered 90% of the interview questions.